All right, so Dr. Kent and I will get started. Anyone that has joined us before, please feel free to interrupt at any point that you have a question or a statement, and we will take questions throughout the presentation. Just unmute and let us know you have a question, and we'll also can talk about some questions or some discussion following. So I am going to get started. So today we are covering neurocognitive disorder in individuals with IDD, and that is formerly dementia. So what is major neurocognitive disorder? So this disorder is a decline in the mental ability severe enough to interfere with independence and daily life. When the DSM-5 was updated, this term, major neurocognitive disorder and minor neurocognitive disorder, replaces the term dementia. Although the terms are now different, they really have little effect on the person-centered and abilities-based approach to care. In thinking about the word dementia, so that word is related to the Latin word for mad or insane. Therefore, the introduction of this terminology does attempt to reduce the stigma associated with both the word dementia and the condition it refers to. Major neurocognitive disorder, or formerly dementia, as we will use both terms here, is not a disease itself. But it's a group of symptoms that can accompany certain diseases or conditions. And we will go into more detail about those diseases and conditions throughout this presentation. It is a broad term that can be defined as a condition involving impairment in thinking, remembering, and reasoning, which affect the person's function and safety. Dementia can occur at any time in a person's life, but it does occur more frequently in older adults. It's also not inevitable of normal aging. So, I know I joke with my own mom, like, Mom, I think you're getting a little dementia because you forgot to do certain things, but it's not normal aging. It is above and beyond, as we will further discuss throughout today's training. Specific symptoms of major neurocognitive disorder include evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. So these domains include complex attention, executive functioning, learning, memory, language, perceptual motor, or social cognition. It also includes cognitive deficits that interfere with independence in everyday activities. And the cognitive deficits don't occur exclusively in the context of a delirium and are not better explained by another mental disorder. Risk for aging associated dementia within the typically developing population rarely occurs prior to age 60 and increases thereafter, with approximately 30% of the population over 80 affected. Obviously, there is substantial heterogeneity, sorry, I can't say that word, in individual risk, and considerable progress has been made in determining that genetics as well as environmental factors may contribute. There have only been 2 large studies in the population of IDD regarding the risk for dementia, and they did look at individuals IDD 65 years or older. Both omitted adults with Down syndrome, given that there's a very high risk of Alzheimer's in that population, which we will talk about more during this training. One of these studies found no evidence of increased risk compared to with findings for the general population, while the other study found the exact opposite of an increased risk in this population. So given the conflict, it's really not clear. More research is needed to gain a better understanding of the relative risk for development of major neurocognitive disorder in this population compared to the general population.
Often the first stop for diagnosis and assessment is the neurologist and the psychiatrist. Neurologists will tend to examine the nerves, do a full exam, see if there's any motor, any sensory dysfunction. They can also do a clinical assessment of cognitive abilities and a brief mental status. Likewise, psychiatrists may use the mini mental status exam. Thorough history is extremely important, and both specialists should gather that from loved ones and the systems that work with the individuals. Psychometric testing, that's defined as measuring the mental capacities and processes. The mini mental status that I mentioned before, it takes about 10 minutes to complete. It's a scoring range of 0 to 30, and it looks at things like reading ability, writing, short-term memory, orientation, and calculation ability. There are other many more thorough screenings that can be administered that look at the present functioning, and then you could compare it to how they were functioning in the past to see if it's progressing. Often scans are looked at as well. MRI, I'm sure everybody knows, is a magnetic resonance imaging. It looks at anatomy right at that point in time. It's extremely important because you're able to find things like a tumor that could be impacting on the cognitive abilities. You might find a cyst. You could see stroke damage. You're looking at changes and loss in the gray matter of the upper brain. Certain types of abnormalities look different on the scans. Alzheimer's, for example, is something called amyloid proteins that form these little plaques on the brain. And they're often described as neurofibrillary tangles that are localized and they cause cell death and can expand and increase in their invasiveness. Now, PET scans, those are very different. That's a positron emission tomography. It's much more advanced. It doesn't just look at anatomy, it looks at the actual functioning of the brain. It complements the MRI because you can actually see where the metabolism is altered. So if you have something called hypometabolism, there's a decreased functioning as the cells die. Now, unfortunately, one of the biggest problems in getting PET scans is that they're very expensive and they're not going to be covered very often. What it could also do is look at vascular functioning. Not only can you see a big stroke like you might see in an MRI, but you would notice decreased perfusion and what's called small vessel disease, which is really important because it's not always this all or nothing big massive stroke. You could have this gradual cognitive impairment as little by little these small vessels are not working properly. Okay, now Alzheimer's, of course, is the most common cause of dementia that people think of when they're thinking of dementia in general. Several million cases per year are diagnosed. No cures, but there are some treatments that can help. It's a chronic disorder and can take many years to progress. It devastatingly diminishes memory and other important mental functions. The connections of the cells as well as themselves degenerate and they die. As I said before, it's associated with these deposits of amyloid and these tangles that happen. Now, frontotemporal lobe degeneration is one of the more common causes of dementia in those under 60. The damage seems to be from clumps of inappropriately aggregating protein. They damage and decrease functioning, and there's about a 6 to 8 year life expectancy once that diagnosis is made. Now, what I think is interesting for us to think about is, think of the name, frontotemporal. So that's where the damage is in the brain. So think about what you're going to see. You're going to see impairment in judgment, decreased empathy, inappropriate behavior, and mood changes. As the damage spreads more towards the back, more towards the midbrain of the frontal lobe, then you'll start to see language problems be added on top of it. Now, Lewy body dementia. There's another particular protein that's involved in the damage. It's called the alpha-synuclein. Lewy body is considered an umbrella term that encompasses Parkinsonian dementia. It's a similar protein that leads to the damage in both cases. In both, you see motor symptoms as well as dementia. Sleep disorders and visual hallucinations are also super common. Dementia with Lewy body and Parkinson's are distinguished by the timing when cognitive and motor symptoms appear. In Parkinson's, usually you see the motor symptoms first, and the diagnosis of Parkinson's is well established, then you start to see it lead into the dementia. In Lewy body dementia, the dementia occurs either first or exactly at the same time as the motor symptoms. And the decline is really fast, usually, not always, but usually faster than you'll see in regular Alzheimer's. Now, vascular disease, of course, can affect cognition. Why it's on this list because while a stroke is obvious and there'll be an acute onset of damage, that's not the only thing that can occur due to impaired blood flow. What I want to point out, and I kind of started on the other side, was to say small vessel disease is important because it's insidious, it's chronic, and it could build over the years. And the reason that's not an unimportant thing to distinguish, because you could say, okay, I found that, what's the big deal? Well, actually, you could do things then. You could use anticoagulants, you could affect diet, you could affect exercise. You actually can catch that early and do some good for the patient. Now, traumatic brain injury, of course, will have an impact wherever that happens to be in the brain. If it's in areas associated with cognition or language, that's where you'll see the deficits. That too, of course, is going to be a more acute onset. Substance and medication abuse not only has an immediate impact on the individual, if someone continuously uses an excessive amount of substances, that can start to look like dementia and in fact cause a dementia type process. HIV dementia, well, obviously there's a diagnosis of HIV, so that's not a hard one to make, but it's important to point out because it's very diffuse, it's pervasive, and it's just severe and awful. It's a very life-threatening component of HIV. Now, prion disease, that is a freaky one. It's like a Stephen King novel. It's really bizarre. It's what's called a spongiform encephalopathy, which means your brain tissue starts to deteriorate and take on a spongy, damaged consistency. So again, really kind of freaky. What prions are, they are transmissible pathogens. They're actually smaller than viruses, and they make these little folding proteins that damage and slowly eat away at the brain. Now, they're not contagious human to human, but they can be caught from ingestion. You guys probably heard of mad cow disease. That was an example, and people were getting it from eating the diseased meat and getting the dementia from that. A type of that is Crutchfield-Jakob disease. And I had a woman in my internship, I think she was in her early 30s, and it was the saddest thing ever. I mean, it's just crazy fast deterioration. Not a whole lot you could do about it, but just something good to be aware of that exists. Lastly, Huntington's disease. Huntington's, again, most people probably know, is a genetic disorder. Autosomal dominant means if you get the one gene, you're going to get the disease. What's always been so challenging about this disease is that it presents usually after the age of 30. So for many people, they didn't know if they had it, and they had a very tough decision to make whether to have a child and have a 50-50 shot of giving it onto their child, because you just didn't know what the future was going to hold. I had a former patient who was married to someone with that, and the guy got depressed. Unfortunately, he ended up suiciding. He was so afraid to have a child and pass it on. It just was devastating to see the person live with it. And another example, I had a policeman, totally fine, and it started in tremors in the hand, and then they get what's called like a writhing or choreiform movement where the arm kind of goes like that, and then the decline cognitively happens after. Difficult to handle, but important to be on that differential diagnosis list, because Huntington's is something we'll see also.
Okay, so dementia impacts a lot of different areas. So obviously memory is the one that all of us think of first, is when the memory starts to go. But it also impacts attention and focus, their individual sensory perception, their language skills and the ability to communicate, their judgment and their reasoning in their problem solving, their ability to sequence tasks and know what to do first, behavior regulation, their self-care skills, their eating habits or their appetites, as well as their safety. And as I even read through this list and in preparing for this training, a lot of these things are deficits that we already see in our population that all of us work with. So we already see difficulty in attention or language skills or sensory or behavior regulation. So really keeping in mind that dementia is the change from that person's baseline. So it's not as though we're looking at dementia as in our population as a change from a neurotypical's baseline. It's from their baseline. So just something to keep in mind, as a lot of the things on this list are things that we see to some degree in our population already. So there are stages to dementia. So stage 1, it's not considered dementia. There's no real cognitive decline. The person's functioning normally, has no memory loss, mentally healthy. They would be, considered in stage 1. There's no major concern at this point. Stage 2 would still be considered no dementia, but there's a very mild cognitive decline. So this stage is used to describe normal forgetfulness associated with aging. Symptoms are not evident to loved ones or the physicians. So this is, as I tell my mom, she's in stage 2. They're a little forgetful, but it's normal with where they're at in their progression. Stage 3 would also be considered no dementia, but now we're moving into a mild cognitive decline. So we went from very mild to mild. So this includes increased forgetfulness, slight difficulty concentrating, decreased work performance. They may get lost more often or have difficulty finding the right words. So it's a little bit more obvious. Stage 4 is where we're getting into the dementia. So stage 4 would be considered an early stage. So there's a moderate cognitive decline at stage 4. So this stage includes difficulty concentrating, decreased memory or of recent events, difficulties managing their finances or traveling alone to new locations. People in stage 4 may have trouble completing complex tasks efficiently or accurately. They may be in denial about their symptoms. They may also start withdrawing from family or friends because of those symptoms and wanting to hide them. Stage 5, we're at a mid-stage, and that we're at a moderately severe cognitive decline. So in this stage, people have major memory deficiencies and they need assistance to complete their daily activities. Memory loss is more prominent, may include major relevant aspects of current lives. For example, people may not remember their address or their phone number. They may not know the time or day or where they are. So again, this stage at stage 5 is when they really need more assistance than they typically did at baseline to get through their day safely. Stage 6 escalates to mid-stage and is a severe cognitive decline. So people in stage 6 require extensive assistance to carry out their daily activities. They start to forget names of close family members. Many people can remember only some details of their earlier life. They also can have difficulty counting down from 10 and finishing tasks that they used to be able to complete. Incontinence becomes a problem in this stage. Their ability to speak declines. Personality changes are noted. They may have delusions, compulsions, or anxiety, and agitation may occur. And again, keep in the back of your mind as we're talking about these stages of dementia, when we're applying them to our population, it's a change in their typical baseline. And then stage 7 is considered late stage dementia. And the decline is at a very severe cognitive decline. So people in this stage have essentially no ability to speak or communicate. They require assistance with most activities, using the bathroom, eating, etc. They often lose psychomotor skills. They may lose the ability to walk. So severe decline from their baseline. Oftentimes the stage 6 and stage 7 is when people are looking at nursing homes and really needing that 24/7 support from a larger group of people to be able to maintain their safety. So there are 7 A's within the dementia world. So the first one is amnesia. So this is a short-term and eventually long-term memory problem. So that just describes the memory concern associated. Agnosia, they can no longer recognize things using their senses. So their sense of smell, taste, things like that, they can't recognize. There's certain tastes or smells that are very poignant and we know very easily. And that starts to lose for these individuals. Aphasia, loss of the ability to speak, understand words, read, or write. Apraxia, loss of the body's ability to perform purposeful movement. Altered perception, misinterpreting the information your senses give you. This can get very, very concerning with safety regarding touch. So someone with dementia might have an altered perception and touch a hot stove, and their brain is misinterpreting those senses and they're not telling them it's hot, move your hand, and they can get burned. So that's just one example of that. The next one, and I practice saying, and I know I'm going to say it wrong, but anosognosia, ability to understand that something has changed and is wrong with you, unable to see the changes in abilities that others see. This is really common in dementia, especially in those late stages. Someone might say to them that, you're no longer able to use the bathroom independently, and they don't see the changes in themselves. Anyone that has, a family member or someone close to them that had dementia can probably, remember times when this was accurate. I know that my grandmother had dementia and she just felt like she could still drive. And yet when we took her license and her car, she had driven through the garage, but does not understand and doesn't see what we were seeing as to why she was no longer able to do those activities. And apathy is the last A. And that's loss of initiative. Really not able to take that initiative to do things for themselves, really needing that support to get through their day. Okay. So changes in sensory processing is something that is very common within individuals with dementia. So as we're talking about, dementia is more than just memory problems. Cognitive problems can be exacerbated by sensory issues. So to start with sight, information travels from the eyes to the brain, where it's interpreted alongside information from other senses, their thoughts, their memories. If an individual has 20/20 vision and still experiences problems seeing, this might be because they have visual perception or spatial awareness difficulties. Research calls this brain blindness, meaning that your eyes can see, but your brain does not interpret the information immediately. So this is a really important thing to know, is that they may have trouble seeing, they may be squinting, they may not be able to process what they're seeing or what you're showing them visually. And it doesn't mean that they have an actual sight issue. So you take them to the eye doctor and they have 20/20 vision, or their sight hasn't changed. There still could be something going on, a disconnect between the brain and their eyes in being able to interpret the information. So what helps this? So giving the individual time to process information is really important. Sometimes it just takes a little bit longer. Ensuring that they have glasses if it's needed. Ensuring that the lighting is bright. You want to reduce shadows. You don't want them to be confused by other things in the environment if there is a shadow. Utilizing plain backgrounds, carpets. So if you're thinking about the environment within a group home or the family's home, and an individual struggling in this area, kind of neutralizing some of the environment can help their vision interpretation. And if double vision is of concern after you've talked to any providers, prisms can assist, and an ophthalmologist should be consulted. So moving on to hearing. So hypersensitivity to noise and certain tones are really concerning. So they're sensitive to noisy environments, and it can cause information overload, which may lead to social isolation. So what helps this? Giving the individual time to process, consistent theme that we will talk about, using reflective listening by repeating what they have said back to them, scheduling quiet time in their day to relax, reducing as much as possible sudden or unexpected noises and sensory overload, as this can lead to confusion. So really making sure that the environment is calm as possible. When going out in the community, trying to organize during quiet times. So for example, we don't want to not go in the community, even if this is of concern. But if you want to go to dinner, maybe going for an early dinner when you know it's not going to be during peak time and that the restaurant will be a little bit quieter. Right now with COVID, obviously our community time is a little bit different, but even an example I always use is the mall. You know, our guys love going to the mall, and even if they're dealing with dementia, they love going to the mall and shopping and walking around. But it can be very overstimulating in their hearing senses when they go during Christmas time, or they go during those peak shopping hours. So just being mindful of the activities that are planned. Providing earplugs to reduce noise is also an option. Sometimes people use headphones. Also sit the individual at the end of a table during meals, as this reduces noise and how it kind of circulates around the table. And then the last three senses of touch, taste, and smell. So changes in these senses occur for individuals with dementia. So it's been noted that they often cannot differentiate between hot and cold temperatures, like I gave that example of the touching the stove earlier. Changes in taste often affects their appetite and their eating habits. So you might notice that things that they really loved before, now they don't love, or they get upset if it's being served. This is not necessarily just trying to get their way. It's actually due to their taste. Smells may also become more intense and overpowering. So you want to be really careful what's brought into the home. You know, sometimes if they may actually react to a staff member's perfume, it may not be that overpowering to all of us, but for them, it may be more intense for them. So some things that help: reassurance, distraction, checking those environmental conditions, being careful about scents that are used, and checking for infection, making sure that there's no UTIs or there's no medical conditions that are also impacting these changes that we're noting.
All right, so we've talked before, and Elise alluded to, dementia will cause an impairment in language skills. The person may not be able to find the right words to tell you something. You may not be able to understand the words you're using. Expressive skills and receptive skills are located in different areas of the brain. So you could see one area go first, the other area go first, or it could be in a combination. So it's kind of important to learn to communicate with them in different ways. This could include drawing pictures of things, having the individual point to them. I've had patients who use pictures of food, pictures of the bathroom, things they wanted to do and wanted to communicate, but they couldn't do it with the words. You don't want to assume that because they can't express something that they do not have the ability to understand it. That's not always the case. A very interesting thing that you see is that the more recent language is lost before the early language. This is why you'll sometimes see people describing scenes from early childhood more easily than actually what's going on at the moment. It's part of the actual short-term memory loss, but the word skills vary. I've seen this in people that speak multiple languages. I was only able to communicate them with the language of their childhood once the dementia progressed. I had this one woman who spoke Spanish. She grew up in Puerto Rico and she lost her English. So her daughter got us this device where I would speak English, it would come out in Spanish and vice versa. And kind of like one I saw on this show called 90 Day Fiance, not that I watched that reality stuff. That is the one that they used, and it was very, very helpful. So last point of communication, behavioral health symptoms, of course, can arise as an attempt to communicate. I think we need to keep that in mind. Think of the frustration if your hunger is not being met, you have to go to the bathroom, your needs are not being met, or if you're in pain and those needs aren't being communicated or met. A lot of time that will then come out in the behavioral health symptoms that we see. It's not new information to tell people that symptoms of dementia obviously are challenging. Oppositional behavior and stubbornness are extremely common. If the individual does not trust the person who's telling them what to do, this is going to arise. They may feel unsafe and therefore not want to cooperate. Imagine if you're in a situation and you're not sure where you are, who's talking to you, your most basic primitive needs are not guaranteed to be met. You know, obviously we all have some anxiety, 2020, clearly we all have more anxiety than we probably like. But I'm hoping there's not one of us where we don't know, where's my next meal coming from? Where am I going to be sleeping tonight? And mind you, this is going on without being properly grounded by orientation and time. So it's almost truly impossible to imagine what that must be like to experience. You know, we term it anxiety and paranoia, but it's kind of understandable how the individual gets to that point when survival is perceived as so uncertain, because they really are so disoriented and so disconnected. Because of that, verbal and physical agitation are going to be experienced. If someone's getting close to you and you don't understand why, who they are, and what they're going to do, the natural response of an organism would be to step back or lash out to preserve safe distance. Even if it's for personal care, that's very intimate and threatening, and it's a very threatening experience if you're not understanding what's going on. And one thing I wanted to mention about sexual expression. As you're all probably aware, sexual urges can be a very primitive response. Lower areas of the brain are involved in this, and the higher levels of the brain tend to fine tune it and make it more appropriate. If the frontal lobe is damaged from dementia and there's sexual urge, it may not allow for the proper social judgment. That's why it's not unusual to see someone with dementia without clothes. They could be touching themselves or trying to do that to someone else. The part of the brain that regulates this is not functioning properly.
I just want to take a second before we continue on to see if there are any questions that anyone has and has been holding on to. If there's anything that Dr. Kent or I can answer before we keep going. Okay, I'll take the silence as permission to keep going. So the next several slides, just to let you know, we're going to be going through some of these more common behavioral symptoms and disruptive symptoms that are seen in the population of dementia, and specifically with our population as well when dementia is a co-occurring condition. And the next couple of slides, as you see with this one, really goes through what could be causing it and some specific strategies to address those verbal outbursts in this case. So with verbal outbursts, some of the causes that you really want to consider when working with someone that has dementia and ID is pain. So they may be in pain. And again, going back to the previous slides from Dr. Kent, they may not be able to accurately communicate it. So the system might need to think about a visual pain board or, some visual way to make sure that they are communicating that they are in pain or uncomfortable. Medication interactions is always a concern and can be an underlying cause of some verbal outbursts. So you want to always ensure that the providers are speaking to each other. Oftentimes from START's perspective, when we get involved in a case, we do this initial, we could call it an eco map, and it's really just a visual representation of the system. And one of the things that's most consistent is that they may have a neurologist and a psychiatrist and a primary care doctor, and then obviously the rest of the system. And oftentimes all of those providers are providing treatment and medication and supports, but they're not communicating. They're all prescribing different things and they may not even know what the other is doing. So it becomes really important, especially when you add the communication factor that our individuals have on top of the dementia, to make sure that the providers are communicating and it's a collaborative effort and that we're very clear on the medication interactions. Loneliness. So loneliness can be a large cause for verbal outbursts and for symptomology in general. They may not feel as though they have appropriate supports. They may forget that you just had a conversation with them or you played a game. So they feel as though no one cares and they're by themselves. Also thinking back to what I talked about with when they're overloaded with sensory and hearing, and they may isolate themselves, that may cause them to have loneliness or boredom. So you want to make sure that those things are being addressed and that they're being engaged. Caregiver interactions, they may misinterpret how the caregiver is speaking to them. At times I've heard when working with this population, they were mean to me, they yelled at me, and that wasn't true. I was there. So they might interpret what they're hearing, what they're seeing, and how they are reacting in that verbal outburst. They may also just simply need something and not know how to communicate it or ask for it. So again, going back to what I talked about with pain, making sure they have a method to communicate that. So some additional strategies, physical evaluation is always really important when it comes to medications or pain related concerns. So making sure that we have a good handle on their physical health. Check the environment. Is it too loud? Are they self-isolating too much? Make sure that the nonverbal caregiver body language is positive. They're taking that information in, and even if your verbal is very positive and caring, if you feel closed off to them, it's going to cause a reaction. Utilize calming music. We're going to talk about music actually in a little while in a couple of slides, but utilizing calming music really does help to bring down their agitation. And then modeling appropriate behavior is always a strategy that is helpful, especially when you're engaging with them, making sure that all of the caregivers, all of the staff that are involved are appropriately interacting with them at the same level.
Some personality types in general are more prone to aggressive behavior. Certainly people with a prior history of a paranoid personality are more likely to feel their rights are being infringed upon or their safety is in question. If there are antisocial features to the personality, there's less empathy and less concern for others. You throw in some narcissism and you've got the proverbial hat trick. It's all about them and how it impacts on their well-being. So lashing out at others will not be questioned as much as it should be by someone with a deeper understanding of empathy. And here I realize my frontal lobe is working because I did not insert a political joke, and there were just so many good ones that I could have thrown in there. So we'll pass that. Okay, so now in dementia, these personality styles are not likely to improve, but they rather worsen, which is not great. It's important not to try to argue away the beliefs of someone with dementia and paranoia. It's not going to work. You really simply acknowledge their concerns, and as Elise said about modeling, stay calm, and that's what you could do. You're not going to have a rational conversation to talk them out of it. Pain and physical discomfort, of course, can lead to the aggressive acting out. Person is afraid their pain is going to worsen, or maybe they'll be touched or impacted in a way that threatens their safety. It's important to acknowledge that, but of course, it's not always obvious to the support system if the pain is not verbally communicated. It's important not to have an anxious, panicky type reaction, even if the individual seems in severe pain and in danger. But again, to try to stay calm and appear not fearful of what the individual is going through. Being concerned is supportive. Looking afraid is not particularly helpful in that moment. In med school, they teach you to have a good poker face. If the crisis is getting out of control, you're appearing to lose it is certainly not going to help the situation. The calmer your facial expression and your voice, it will only lessen the fear of the individual. Now, we've talked somewhat about changes in the brain leading to disinhibition and loss of emotional control. The strategy of staying calm includes not shouting, trying to avoid initial physical contact. The shouting can be sensory overload for the person who is not perceiving it appropriately. As I noted before, their frontal lobe's not working well enough to understand that the person in front of them is getting upset because they're trying to help me and they're worried about me. No, they're just seeing the situation getting more out of control and getting more scary. They don't see that, hey, that person's scared, because they care about me. Physical contact somewhat goes without saying. Person may recoil and feel more threatened if you lay hands on them. Misunderstanding others' actions, of course, is part of defining paranoia. As I said earlier on the slide, don't try to rationally converse and convince them. Listen, acknowledge, and reassure. A simple message calmly repeated is the best strategy. When the person is feeling threatened, I often get asked about the efficacy of eye contact, and it's kind of variable. There's some people that sets them off. The last thing you want to do is stare them in the eye, but there's others where a kind and caring eye contact could help with the situation and help them to connect with you. So you kind of have to know, I kind of connect that to like in the dog world, where there are certain dogs that they make eye contact and they just piss off all the other dogs, and other dogs look away and they look more submissive. So I guess we have to sort of know the audience a little bit and see whether that's reassuring or whether that person picks it up as a bit of a challenge. Distraction is a definite intervention to think about. If we can get the individual distracted to something that's less affectively threatening, that could be a help. It could be listening to music, taking a walk, a silly joke, anything. Modeling appropriate behavior, as Elise said, is always the right thing to do. But ultimately, it's nice to try to figure out the trigger, even if it's not immediately obvious, just for future reference, so we can avoid it down the pike.
So the next symptom is inappropriate sexual expression. So, one of the first causes that you want to think about is those brain changes. And Dr. Ken has gone into that with the changes in the frontal lobe. It causes that reduced inhibition, and that can lead to inappropriate sexual expression, as Dr. Ken mentioned earlier. Some other things that, you want to always keep in mind is their uncomfortability. So are they too hot? Is their clothes too tight? Temperatures, things like that. Those types of things can cause that inappropriate sexual expression. We bring pain right back in. I think pain will probably be, I think pain is on every single one of these. So that's something you always want to clear up first. But specifically with regards to inappropriate sexual expression, they could have a UTI, vaginitis, constipation, hot flashes. So things that are going on in their private parts, and is causing that inappropriate sexual expression. The other thing that you always want to think about, and it's something that I think comes up the least, but it's important to know, is they may mistake their caregiver for their partners. So if they have a staff member, they may think that is their wife that maybe passed away, or someone that was close to them. So they may have that memory loss and that mistake. I know that with my grandmother, when she had dementia related to Alzheimer's, and we had her in a nursing home, my grandfather had passed away like 15 years prior, and she thought he lived there too, and that this other person was her husband, and she had a little bit inappropriate sexual expression. And then she also found out in her eyes that another person in the nursing home was having sexual relations with him, and she, in Italian, because that language came back, was very upset and called her a lot of very, very upsetting Italian words. So it was, we can laugh about it as family, and we calmed her down, but that mistake for caregiver for her really caused this domino effect of issues in that nursing home. So it's something to really keep in mind as you're working with someone with dementia. Some strategies, distracting and redirection, of course, addressing the pain and the medical, as we've talked about, ensuring that they have comfortable clothing. It's loose, it's not too tight, it's not too warm if it's warm out, that they have access to cooling aids and things that can bring their temperature down.
You just reminded me of something funny. I had a elderly Austrian grandmother who had dementia, and she had like 10 grandchildren, me being one of them. We'd come over to the house and she'd go down the line, give $1, $1. She'd get to me and I'd get $50. I'm like, why was I so special? It turned out I apparently looked like her ex. And so I got all this special treatment. So of course I had a lot of money and I didn't tell anybody, and it was wonderful. But yeah, it was totally, I was just perceived as a different person at a different time. So
Yep.
that clearly happened. So, all right, but this slide's not about that. This slide's about
No.
leaving unexpectedly. Not an unusual problem. Why the person leaves, though, is not always the same. Sometimes we mistake that as being, oh, the person just runs, but there's really a lot of reasons here. Maybe they're searching for something. They could believe they're in the wrong environment and they're looking for their home. Maybe searching for a family member or a friend, not realizing it's inappropriate for their particular place and time. If they have dementia, they may not be oriented to person, place, and time. So they're searching for something or someone does not seem foolish to them, but it actually feels appropriate. Escaping from something is also a reason people take off. If they perceive danger in their surroundings, why shouldn't they leave? It's in fact rather logical to make that decision. Reliving the past is definitely associated with leaving. I said before, maybe they're searching for someone in their past or escaping from something that was appropriate to try to run away from in their past. If they've had trauma, maybe they were abused by a parent and running out was a way to seek safety. Maybe running towards an individual may be a way to seek safety and companionship to avoid more trauma. Knowing their history is really important here because that might help us to understand it. Restlessness. This is on the list, and it's for very good reason. Many of the medications we use cause akathisia. And if anyone doesn't know what akathisia, it's the side effect where you can't keep your body still. You have to pace, you have to move your arms, your legs, you just cannot sit still. You feel like you're coming out of your skin. You're not actually worried about anything or anxious about anything. It's a true physical sensation. So these individuals are not looking for anything. They just have got to move. They've got to get out. So I've spoken with people who have had this through the years, patients, and they say it's about one of the most horrific things you could have. So correlation with medication should be looked at when we have people that leave unexpectedly and make sure we're not causing it with the meds. The difference there is you would see an inability to sit still in no matter what their environment in. They don't find the holy grail of the person. If they're outside, they're still bouncing their leg, they're still twirling, they're still moving because their body has to do that. Now, some things to consider strategically are orienting cues to help the person know where they are and not feel the need to escape. Obviously, reducing fall hazards is important too, because you don't want somebody to get hurt. Providing opportunities for movement and engagement are essential. If the person is bored or restless, this will help them get out some of the energy and have some stimulation in their life. Having a safe place to wander can be psychologically positive. During lockdown, how many of us wanted to take a hike, a walk, because we're just sick and tired of the damn same four walls? So yeah, people need to get out and get to move, so that can decrease it a little bit. Try and avoid places that are too busy and confusing. That's fairly obvious. Camouflaging doors and locks can sometimes stop individuals from trying to get out because they don't recognize that that's a means to that end. Lastly, GPS devices can be helpful. The concern here is whether it's a human rights violation. It's a controversial topic. I am no expert in it. I am now working with housing, with free, and I always hear mixed results. but having a Fitbit watch or something where you could safely find someone, to me, makes a lot of sense, but I don't know the legalities of when that can and can't be used, actually. So if anyone in the audience or anyone out here has any information on that, I'd love to know it, because I think it's a great thing for people with dementia.
I just want to add too, I know we talked about, Dr. Ken talked about camouflaging doors and locks, and relating that to fall hazards as well. If in the home there's steps and they are someone that leaves unexpectedly, there are maps that you can put down on the ground that make it almost feel like a black hole for them, that they will then be scared and not want to cross that boundary. So again, within group homes, we got to look at, human rights violations and making sure that those things are all approved. But there are ways that you can put things in front of doorways or steps to ensure their safety regarding leaving unexpectedly, or even just fall hazards in general if their gait is affected, as we talked about earlier. So there are definitely things that are out there that can be put in front of those areas to assist. They're less likely to kind of cross that threshold if it looks like there's nothing there. So again, going back to the GPS tracking stuff with human rights, group homes, things like that need to obviously be cautious on what's allowed and what's not allowed. But for people with dementia, they are things that are really important for their safety and should be explored. Okay, so next up, we have rummaging and hoarding. So this is something that we definitely see a lot with people with dementia. I'm sure everyone can understand why they hold on to their stuff. But so some of the causes that they might rummage, especially, is they can't remember where they put something. So we want to make sure that their environment is organized, but you never want to remove things that you don't, you haven't worked with them in doing, because if we remove something and then a couple of days later they were looking for that one piece of paper, and it may have no important value to us, but again, whatever might be going on for them, whether it be something back in their past or they think it's something that it's actually not, that can cause a lot of the other behavioral health symptoms that we've talked about. This rummaging and hoarding and having a lot of stuff does create a sense of security and safety for them. So having their belongings around them is something that they feel safe with. They have a fear of losing an item, so they may make sure that things are there on a daily basis or keep holding on to things because they never know when they may need it. And boredom is another cause of this symptom. They may be understimulated. So I talked about organizing. So you can also help by making a rummaging box. So creating, like a bin of items that they can safely rummage through and sort through to keep it a little bit organized. Keep an eye on them. Identify the places that the person hides things. They might think I'm putting this, away for safety, and it's, in a very remote place that no one else is going to find something, and then they can't find it because they forgot that safe place. So as staff and as people that are supporting the individuals, keep an eye on where their usual hiding places are so you can always direct them to it. Want to always have them directed to another activity. Make sure that they have active schedules, that they have things to keep them occupied. And another just a pointer is checking waste baskets, garbage pails before you empty them, especially if they're in their bedroom. That might be a hiding place. And if you throw that away, they will then be rummaging later on, trying to find that one item that they can't no longer find. So just something to check on.
Okay, repetitive questions. A complaint you hear from people caring for those with dementia is they never stop repeating themselves. So this begs the question, why is someone continuing to ask the same question over and over again? Well, clearly there's a high probability of not remembering they've asked it. On top of it, there's an inability to retain the short-term information. So when you give them that knowledge, they're unfortunately not able to hold on to it anyway. When an individual is asking a question, it may not be simply out of curiosity or something they just happen to be thinking about. Maybe they're trying to express a specific concern or ask for help. There is likely anxiety underlying and insecurity about having some question on their mind, and they cannot satisfactorily hold on to the answer. Focusing on the emotion behind the behavior is important. Why are they asking this particular question this time? Are they nervous? Are they lonely? Are they sad? Perhaps if we can help them with these emotions and what triggers them, the repetitive questions won't be asked as frequently. Staying calm, as we've spoken about before, is always helpful. Generally, most people recommend provide an answer, keep it short and sweet. Don't go long and long and long. It's not going to get anywhere. But saying, no, I've already answered it isn't really going to help. And so just answering it again briefly probably takes you less time to say, I'm not going to answer it. So usually that's what you do, just a short, reassuring, brief, free answer, and just expect that that's going to happen again. Distracting the person from the question is not being mean, but it may in fact be helpful. You're not just helping yourself to not be bothered, you're helping the individual not be bothered by having to keep asking it themselves in the first place. Memory aids can be helpful. That's why often you'll see schedules with the times written in an individual's room. You'll see pictures of people in their lives with their names next to them and when to expect them. I find that's a big help for my patients, either on the spectrum with cognitive limitations and obsessive compulsive features, or my dementia patients. So there's a visual they could see, this is when it's happening, this is who it's happening, and it can reduce the questions a little bit. Anything that you can do that taps into alternative ways to calm the brain for that person can potentially be beneficial.
Okay, so moving away a little bit from the behavioral health symptoms associated with dementia, we're going to jump into a little bit of Alzheimer's disease, which is the most common form of dementia related to older age. Alzheimer's is a type of dementia. It affects memory, thinking, and behavior. Symptoms eventually grow severe enough to interfere with their daily tasks. So again, we talked about that earlier, that with dementia, it's not just a memory loss, it's that impact to those daily tasks. As I said, Alzheimer's is the most common cause of dementia. It accounts for 60 to 80% of dementia cases. As stated earlier, it's not a normal part of aging. So not everyone has Alzheimer's or dementia, even if they're losing a little bit of their memory. The greatest risk factor is increasing age, and the majority of people with Alzheimer's are 65 and older. But Alzheimer's is not just a disease of old age. There's approximately 200,000 Americans under the age of 65 that have what's called younger onset Alzheimer's disease, also known as early onset Alzheimer's. It's important to know that it is progressive. Alzheimer's will worsen over time. So we did talk earlier about those stages of dementia. So that's that worsening pattern. In its early stage, memory loss is often mild, but with late stage Alzheimer's, individuals lose the ability to carry on a conversation and respond to their environment appropriately. It was really interesting to me to find out that Alzheimer's is the 6th leading cause of death in the US. So that was really, really interesting. On average, a person with Alzheimer's lives about 4 to 8 years after diagnosis, but can live as long as 20. It really depends on other factors and their medical status outside of the Alzheimer's disease. There's currently no cure. Treatments are for symptoms-based. They are available. Research does continue. As I cited earlier, there's research within our population of ID and dementia, but 2 studies came out with 2 different answers. So a lot more research just in general of Alzheimer's and dementia, as well as with our population, is really needed. And although current Alzheimer's treatments cannot stop it from progressing, they can temporarily slow the worsening of dementia symptoms and improve their quality of life for those with Alzheimer's, as well as the quality of the life for their caregivers. As anyone that has had a family member or someone that they've cared for in a group home or in their career, it does impact the caregivers quite a bit to work with someone with Alzheimer's or dementia. Treatment will be discussed in a future slide by Dr. Kent as well. As we talked about earlier as well, the last skills that they gained are lost first, and it goes back in that order. So if we've just recently taught them how to tie their shoes, that's going to be the first thing that they lose. One of the most common early symptoms of Alzheimer's is difficulty remembering newly learned information because of that last skills learned lost first. So Alzheimer's changes typically begin in the part of the brain that affects learning. As the disease advances through the brain, it leads to increasingly severe symptoms, including disorientation, mood and behavior changes, deepening confusion about events, time and place, unfounded suspicions about family, My grandmother always thought that we stole from her. Friends and professional caregivers as well. More serious memory loss and behavior changes also accompany Alzheimer's. And there also is difficulty speaking, swallowing, and walking. So oftentimes in the late stage Alzheimer's, dementia, they may need changes to the consistency of their food because their swallowing is impacted, or they may be wheelchair bound because it's impacted their ability to walk. People with memory loss or other possible signs of Alzheimer's may find it hard to recognize that they have a problem. It's very frequent that it's more obvious to people around them than themselves. So that is something to also keep in mind. It's also, anyone that's tried to have that conversation with a loved one, it's also really difficult and can be really challenging and upsetting. It is important to understand a bit about Alzheimer's and the brain. So microscopic changes in the brain begin long before the first sign of memory loss. So we don't see any symptoms, but those changes have already started. The brain has 100 billion nerve cells. Each nerve cell connects with many others to form communication networks. The groups of those nerve cells have special jobs. Some are involved in thinking, in learning, in remembering. Others may help us see, hear, smell, be related to our senses. To do their work, the brain cells operate like little tiny factories. They receive supplies, they generate energy, they construct equipment, they get rid of waste. The cells also process and store information and communicate with other cells. So there's these little factories going on in our brains. Keeping everything running within our brain requires coordination as well as large amounts of fuel and oxygen. So scientists believe that with Alzheimer's disease, it prevents the parts of the cell's factory from running well. They are not sure where the trouble starts, but just like a real factory, backups and breakdowns in one system cause problems in other areas. As damage spreads, cells lose their ability to do their jobs and they eventually die, which causes those irreversible changes in the brain that we then see in the symptoms related to Alzheimer's disease and dementia. So this video has been circulating around the internet. Dr. Kent actually sent it to me for us to use in the PowerPoint, and it was really amazing. And after he sent it, I feel like I saw it everywhere on social media and the news. So it's this video, I'm going to hit play in just a second, but it's regarding music memory in regards to people with dementia. So music memories are often preserved in Alzheimer's due to the key brain areas linked to musical memory being relatively undamaged by the disease based on where in the brain it is. Music can relieve stress, reduce anxiety and depression, reduce agitation. And the video that we are going to see is of an elderly woman who was a former New York City ballet dancer. And as you will see, music is played that reminds her of her time being a ballet dancer. And you will see that she actually gets brought back to that time of her
This is a story of the cult favorite, best-selling, waitlist-inducing, always packed.
Unfortunately, there was an ad, but here we go.
Me emociona.
Isn't that just amazing? This video was great. Unfortunately, the rest of the video is not in English, and discussing it with her, but it's a fantastic representation of how that musical memory works for someone that has pretty advanced Alzheimer's disease.
She nailed it. She nailed it.
You nailed it, right?
Nailed it.
So impressive. Dr. Kent, did you want to add anything about the music memory before we keep moving forward?
No, I kind of think it speaks for itself. It's amazing.
Yeah, absolutely. Okay.
Okay, this is me, right? Yep.
It is.
Okay, that threw me off. She could remember that. I couldn't remember which slide's mine now. All right. So there appears to be a correlation with Down syndrome and dementia. 100% of adults with Down syndrome seem to have some of those plaques and tangles that you see in Alzheimer's that I mentioned before. This is observed on autopsy. However, they don't all develop the dementia. It appears that about 60% do, which is actually an important point in general. 60 Minutes this week, I don't know if anybody saw it, but they looked at the 90 plus population and they did autopsies, and they had brains of people that were driving and high functioning and not an ounce of cognitive impairment, and their brain was covered with this stuff. So it's not a death sentence for everyone. They had some kind of genetic protection and they're not sure why. So I just think it's important to note that it correlates with dementia, but it's not a one-to-one, thing that if you have that, you'll definitely have the dementia. So as you mentioned, there's a prodromal period. That means when the disease is occurring, but there's not yet any symptoms. And that's very clear in Down syndrome. The actual changes in the brain in Down seem to start about age 20 to 30, but the dementia symptoms were 10 to 12 years delayed in Down syndrome. Scientists aren't quite sure why this is the case, but it does. What happens due to this is that there are times where it's simply assumed that an individual with Down syndrome has dementia, and they may not. So we may get a case that we look at and they'll say they're not sharp, they're losing it, it's dementia. And then say, okay, we don't need to do anything about it, that's just what it is. The reason that's not okay is maybe there's something treatable going on and it's actually not dementia that we're looking at. So what if their cognitive decline was due to medication changes? Too much medication that's cognitively blunting them. What if it was due to metabolic issues and blood vessel disease? Well, in these cases, clearly we can lower the meds. We could change the diet. We could look at, again, something that lowers cholesterol. We can get the person walking and exercising. So you would never consider these interventions if just made the assumption, Down syndrome, Alzheimer's disease, we see the plaques on the scan, that's it, it's over. It isn't over. There are other things that could be affecting it. That's the point of this slide. In Down syndrome, there is a decreased lifespan and early aging, but we want to assume that they get the maximum and the most out of their life that they can. That's why you need to tease this apart a little bit. All right, limbic system. The limbic system is important to mention when discussing impairment in the higher functioning areas of the brain, such as the frontal lobe. The limbic system is more of that primitive area I talked about before that we share in common with less developed organisms. It's connected with primal feelings and experiences like rage and fear and panic. What the limbic system does, it takes data from and sensations from the outside world, tries to assess what it is, why it's occurring, and how to respond to it. If you think of the limbic system sort of as the butler that's answering the door and trying to assess whether it's friend or foe, the only problem, think of the butler as being intellectually limited and in terms of abstract thinking and problem solving. The butler is actually not all that oriented to person, place, and time. It can tap into some memories and try and access guidance, but it then struggles to differentiate whether what it's seeing now is actually present or is it picking up some info from the past that's correlated with this. All the more problematic if the individual is a trauma survivor. So now what do the higher levels of the brain do, including the frontal lobe? They help out the butler. Butler relays this information, and that part of the brain says, hey, wait a minute, this is friend, this is enemy, and it puts the stimuli into context. It can say, hey, you know what? You're panicking because that thing at the door is reminding you of something that happened 20 years ago. That smell that you're having, that was the smell that was going on when you were sitting in the house and something bad happened. It can safeguard that and calm the person down. When there's dementia, the individual is at mercy of that inappropriate and inaccurate assessment of what's going on right at that moment. Sad example, but I think a good one to really show this is one of my best friend's dads had dementia. He was a survivor of the Holocaust, and every time there was a knock at the door or the doorbell, they would find him under the table, and he'd be yelling that the Germans were coming after him. He would want a gun. He would need reassurance, but it never really helped. What was going through, he was experiencing that as if it was back in the 40s, and in fact, somebody was there to really try to kill him. So for him, that was not a crazy response. It's just in 2020, it was a bizarre response and clearly not the right thing. So while dementia damages the higher function areas of the brain, how they interact with the limbic system is sort of critical in understanding why that person is having such odd behavioral health symptoms. When a staff member is being attacked and cursed at, that individual may not be in that moment along with them, and they may see that staff member as somebody else from past trauma. That doesn't make it any more fun for the staff member. It doesn't make it any less dangerous for the staff member. But I think when we help them to understand where it's coming from, it's just a depth of understanding it and gives them a little better sense of tools of how to address it. That the person attacking them may not be mean, may not be vicious. They're frightened, confused, and clearly disoriented to person, place, and time.
Okay, so let's pull it all together. So we talked a lot about what impacts dementia, how it might come about, the brain functioning. We talked a lot about specific behavioral health symptoms that we might see and what to do in those areas. But in general, there's a lot of ways to support an individual with dementia. So we want to focus on balancing the ease of use for various items with their limited sensory stimulation. So thinking about what I talked about regarding sensory, if we're seeing a sensory deficit in a specific area, we want to really balance that ease in those areas and make sure that we're adapting the environment and their tools to help them in those situations. Being predictable and having consistency is incredibly important. You do not want to kind of go off the cuff and not have a plan. So like Dr. Kent was talking about earlier with visual schedules and things like that, that predictability of what comes next and that consistent schedule or that consistent redirection to that visual schedule is very helpful for them to kind of get their understanding of what's going to happen each day. Maintaining function and social interaction as much as possible. As I talked about earlier, they do self-isolate quite a bit, and it might be easier for us to just set them up with something and have them stay in their room because we're worried about their safety or we're worried about interactions or some of those behavioral health symptoms, but that is not going to help them flourish and help support them. So making sure that we're maintaining their function, their social interaction. If they're struggling with their walking, we still can take them outside and go for a walk. Maybe it's using a wheelchair. Making sure that they're still brought out in the community right now, COVID dependent, of course, and making sure safe in that area, but making sure that they still have activities that bring them joy. Providing them limited choices. So although we always want to be person-centered, so this is something to think about, but sometimes we might not be able to give them as many choices as other individuals. Maybe an average individual that we're working with can handle 3 or 4 choices at once. Someone with dementia, that will cause them a lot of confusion. So giving them 1 or 2 choices at a time, very, very concrete, very easy, things that they can make decisions about. We obviously still want them to be involved in their decisions of their life, but again, we might need to limit that a little bit for it to be successful. Failure-free activities. So we want them to have a really great positive life and not to feel sad or frustrated. So if we give them an 80-piece puzzle that we know they can't complete, that is not a failure-free activity. Maybe give them a 20-piece puzzle. They love puzzles, but maybe we need to make it failure-free. Maybe we need to kind of give them opportunities to do things that they can feel really proud of themselves for and achieve. Anyone that's involved in START with us knows that we talk about PERMA a lot, and we want to make sure that they have their well-being and that they're having their achievement and they're engaged in things that bring them joy and put them in flow. And that still remains for someone with dementia, even with the added difficulties in doing so. We want to make sure that we have increased options for their care. It is on a continuum, and obviously, certain times we may need to increase staffing or think about whether their environment is the most protective for them. But this does not mean institutionalization or anything severe. But sometimes we might need to think about, is this the best environment for them? Can we provide them the best care and support? Validation is really supportive for someone with dementia. That does not mean that we always have to agree with everything that they're saying. If they say that the sky is green and the grass is blue, that's okay. That's great. Why argue that point, right? It's not something that's worth it. So always validating their opinions, validating their feelings, validating their thoughts, and just trying to help them have a really happy life. Being empathetic and understanding kind of goes without saying. We've talked about this already, but really just making sure that they feel cared for, that they know that they have people to communicate with and to help them. This goes back to what I said earlier, but not to fight them, not telling them that they're wrong. Sometimes someone with dementia, especially someone with dementia and ID, may come up with something pretty wacky, but again, picking your battles, and you don't need to tell them that they're wrong, and cause any additional distress. Distraction is a huge way to support an individual with dementia. Keep them engaged in activities that they enjoy. Have a dance party. Music, as we just saw, is a huge method of support. So, put some positive music on, have a dance party, let them enjoy themselves, keep them engaged and distracted. It's also important, as though this is not a strategy, but it's something that we really want to make sure that you keep in mind. Someone with dementia does not see and interpret the world the same way we do, or the same way that they used to. So we might have been supporting an individual in a group home, center, for example, for 20 years. And, in the last 4 or 5 years, some of the ways that they see the world and they interact and they're experiencing life has changed. So the expectations of the way they were 20 years ago, now that they have dementia, cannot be continued. And just remembering that we might interpret something as a really positive experience and they may be upset about it. And it doesn't mean that they're wrong. As we talked about a lot in this presentation, the change to their brain is very valid and it's a concern. So we want to obviously always keep that in mind. We want to make sure that we see the world as they do. So try to put ourselves in their shoes, try to observe and learn about how they interpret different things. That will help support them and make them feel safe. They may interpret a specific nonverbal cue that we see as not threatening or upsetting as very upsetting and threatening. So if we can find those consistencies in how they're reacting and adjust for them, that's the way that we can support them even further and make them feel safe in their own environments. Being patient, supportive, understanding. As Dr. Kent talked about earlier, their symptoms, their behavior should be considered as communication. It also should be considered in the context of the environment. So again, all of those environmental things that we've talked about today should be kept in mind and make sure that we're addressing those as early as possible. You also want to change the environment, not the person. So if we go back to some of those sensory things I talked about and we realize that the environment is maybe too bright or there's a ton of shadows, we're not going to be able to expect that the person's going to change in how they're viewing that environment and how their sense of sight is going to change. We need to change the environment. And it's the same thing when it comes to the behavioral health symptoms that we're seeing. Not expecting them to change is really important, and changing what's going on around them. As the disease progresses, we need to change our way of communicating. Those nonverbal communications becomes even more important. Those nonverbal, abilities become even more important. The visual, talking about pain boards or visual schedules, all of those things become even more important than it did prior to the onset of the disease. Anytime you enter a room or you're talking to the person, identify yourself, not making them feel as though they can't ask, who are you again? Even if they've known you for 10 years, making sure they know who they're talking to and who's there to support them. Dr. Kent talked about this earlier, but remaining calm. It's very easy for us to get flustered or anxious when working with this population and someone with dementia, but us being calm and patient and having a low level of anxiety or not showing that anxiety is really important for them. They pick up on what's happening around them, and sometimes they view that differently than we may intend. Smiling. So that goes with those nonverbal communications. Show them that you're happy, that you're glad to be in their presence, and that you want to support them by having a smile on your face. A little more difficult with masks right now, but try to smile with your eyes, I suppose. And maintaining appropriate distance, not getting too close to them, making them uncomfortable, thinking again about that environment and how situations are set up.
A little bit on treatment. Medication treatment in dementia for behavioral health symptoms is obviously needed quite often. Certain basics to just sort of keep in mind. It's very important in this population to be careful with dosing. The rule is start low and go slow. People with dementia are notoriously sensitive to side effects. Sedation and confusion are very common, and those are, you can imagine, two things you certainly don't want to do to somebody with dementia. And you need to know if that's happening, is that a worsening dementia or are you worsening it from the medication? Parkinsonian movements are a common concern when using medication in dementia because that's a side effect of the antipsychotics. With this, you see a shuffling gait, muscle rigidity, less animation in the face, and the facial muscles are tighter. You might see something called a pill rolling tremor. That's when the fingers kind of go like this, like you're rolling a pill between your fingers. And you could get something called cogwheeling and ratcheting. What that is, if you take someone's wrist and you go like this, instead of up and down normally, it has like little ridges, like 1, 2, 3, 4, 5. It gets stuck. So that's what's called cogwheeling rigidity. That's very, very common side effects from the medication. And if you don't look for it, you're just not going to find it. And it's actually could be somewhat painful for these people. So it's worth looking for, when you're putting them on these kind of medicines. You have to check renal, hepatic, and cardiovascular functioning. This is one of the main reasons to go slow because they don't clear the meds as well as somebody healthier and younger. The kidney and the liver have a decreased rate of processing the medications. Cardiovascular concerns are important, in particular heart rate. We want to make sure we're not delaying the cardiac conduction too much and creating arrhythmias. In terms of psychotropic medicines, benzodiazepines can be very calming and they can be used. But clearly there too, you got to be very careful. In this population, if you sedate them and they lose some balance, it's brutal. They get a fall, they fracture something, it's all bets off, and you've really caused their demise. The bones are very brittle. So everything has to be thought through again in terms of down the pike of what each side effect can cause for them. Antipsychotics are often used for paranoia and agitation. And again, of course, as I said, the dose needs to be low. But many of the comments I made before about Parkinsonian side effects and confusion are quite common in antipsychotics, even for the general population, let alone in the dementia population. Lastly, I just wanted to throw out something called black box warning. You might see that. What a black box warning in general means, this class of medicine is warning that it's dangerous to use in that population. Not contraindicated that it can't be used, but you have to look at it carefully. And in particular, in those with dementia, you're worried about stroke and heart attack from antipsychotics. Does not mean you can't use it. Matter of fact, the risk could be worse of not using it. They'll get hurt from the paranoia. It just means you got to check out their heart, their sugar level, their cholesterol, do all the proper things, use it very carefully. But I just think that needs to be explained, because a lot of families will come to me and say, you screwed up. I'm like, well, probably, but what did I do? I don't know what I did today. And they said, well, you wrote something for my parent and it was black box. I said, well, that's not a screw up. I said, if I didn't talk to you about it, that's a screw up. So yeah, they may have gotten me on that. But these meds, we have no choice, but they just have to be used very carefully. We have to educate the system on why they're being used and what the true definition of black box warning means. And that's it for me.